Good morning, everyone, and thank you for joining. My name is Reggie Allen, and I'm the Senior Vice President here for Clinical and Business Operations for Payer Watch and Appeal Masters. I have over 35 years of experience. My background is a registered nurse. I've been a chief nursing officer before, a chief operating officer, and a vice president of an organization. I've also developed and put together a clinical appeals unit that serviced over 40 hospitals, and I have my MBA, and I'm also certified with ACMA. Thank you,
I
Eric.
guess
Yes.
1 second. I'm a little tech slow this morning. Much better picture of me, probably a few years younger, but who doesn't have one online these days? Kendall Smith, a hospitalist by training, technically a hospitalist dinosaur for 25 plus years. My background is in utilization review, care management, denials, audits, and appeals. And in the last 2 years, a significant focus in the application of AI into the denial, audit, and appeal space. I'm the chief medical officer, chief physician advisor. I'm very privileged to be working alongside someone with the wisdom and experience of Reggie, who's going to be leading us today. So, with that, Reggie, I'm going to turn it over to you,
Thank you.
and we'll get started.
Okay, so our goal at the end of the day, of course, as you can see, our learning objectives. I'm sure everybody on this phone is capable of reading very well, but we do want to share with you our experience. Well, we do work for over 600 different organizations, and so we want to be able to share some of the systemic breakdowns that we see with denials and audits, and to be able to look at the data to do that. That's our first goal. The second goal, obviously, is to show you how we translate and deal with root causes. To help us understand how to target physicians and the staff with reeducation and their admission decisions and gatekeeping. The third thing we'll talk about is how to build escalation, because a lot of these things actually really need to go back to the payers, although the hospital has a responsibility in this, but we also, through our experience, also recognize that there are some things on the payer side we need to look at. And then lastly, obviously, is the strength in collaboration between all of those that are working in this space, because this space is not just, as we'll talk about earlier, it's not just a revenue cycle problem, but a lot of issues, especially that we see, are clinical in nature, and they need to they involve the clinicians and compliance, and the data analytics that we have that we can see across departments will help drive that. Next slide. So why is this important? Uh, Kendall, you're the man there of why this is important. Um,
Sure. Um, I've always viewed a denial or a adverse audit finding as a bad outcome, and majority of these, as we get into them, are actually preventable. What that describes is a situation where information that occurs in a vacuum can't be acted upon. So an organization needs to be able to inform and educate and transform itself. And ultimately, denials, audits, and appeals, as disengaged as it seems from care at the bedside or care in the clinic, is the ultimate fact check on how that care is being delivered in accordance or out of boundaries with payer relationships, payer contracts, and payer policies. To that end, having an ability to get reporting into actionable formats starts to inform the hospital system and the providers as to what their exposures are and how to correct them. And ultimately, as revenue margins and operating margins get tighter and tighter, this is going to become an even more critical focus going forward for folks.
and so we'll get in shortly, looking at example of a data analytics and how we do that. But you can always start your own scorecard, as you can see, and we'll show you later. You can get it done on a weekly basis, a monthly. Should be looking at it weekly, monthly, certainly quarterly, and looking at your overturn rates and how long it takes, the time it takes to get them appealed. We'll show some of that. and looking at some of the DRGs to drive it. Now, hopefully, we will provide some examples and kind of show you what we do as we help our clients, because we do operational reviews with our clients. Next slide, please. In this slide, one of the things I always try to do, because I'm come out of the hospital setting and done some work on the payer side, is I try to look at denials as an operational signal. I kind of look at it, it's not just a revenue cycle uh, problem. I kind of look at it like I do an incident report. So as you guys know, when you have an incident report, in our case, what we look for is what's been held versus what's been overturned. What's the reason codes in the narrative? Then we try to transition that to operational vulnerabilities, and what are the workflows that we have where there may be breakdowns or policy issues or documentation. And then we need to, as you know, with a incident report, then you would want to know, let's look at the standard work. If there's something we need to educate people with, in this case on ours, is there some peer engagement that we need to do? And then, just like you would with falls and everything else in the hospital, you obviously would want to, have a dashboard where, if I use falls, for example, where you would start looking at what unit are they occurring on, what type of patients, looking at some of those issues that you can do, where not only that you can monitor, but takes you back to your interventions and things that you can do, hopefully that you can mitigate some of those. Some of the key observations that we have noticed is when denials, when you have overturn and denials, especially at high level, and we'll talk about that with high overturns, there's usually revealed something about the payer behavior on the clinical side, or lack of information to payers, and some weak appeal workflows. So on the side, typically what we're seeing, and we'll talk about that when we get to the root cause, is we typically see they've got an authorization, but that's really for notification. The bigger piece of that is what clinical information is being called in, and that's where sometimes there are gaps that we see with overturned denials, that the clinical piece is not really being called in timely, or if at all, to the payers that would address some of those why some people have high overturn rates. And those are processes people may have in place. And I'll share, just to throw a few things out that for that. It's a whole different conversation if we start looking into best practices in some of these areas. But for upheld denials, usually what we see typically is there's usually some internal process failures, which again could be not getting those clinicals called in, or something that we can standardize and prevent. But that's kind of what we see most of the time when we are having those denials. Go back right there at the workflow. So what we try to do is we use what we call an analytical workflow. When we're looking at this, we look at the data, we see what we can get insightful for it. Then we talk about how we're going to intervene and how we're going to measure. And we usually have 5 steps that we kind of look at. One has to do with ingest. So we get the denials, we get the letters, we want to see the appeal, we want to see the medical record, we want to see what the UR notes look like. I'm very interested in what the length of stay of the patient was. What day of the week did the patient come in? So we're just like going back to the incident report thing. We have to look at all of those things to try to ingest what the problem is. One of the other biggest issues that we see is the lack of normalization. We can see many times when people are doing things just in Excel, or where they're doing things in free text, they don't have a good taxonomy of how they, whether they're doing payers, whether they're doing payer plans, what they're actually using for denial reasons, what the service lines are. Those things are really important, that those things are standardized taxonomy, no different than you have in your E&M system, where you have things pretty standardized. And it's always better if you can have drop downs that you can look at and that things are consistent across. Then we need to classify these things in the right categories. We'll talk a little bit more about root cause categories and how we manage those. We have our root causes in the following categories. We have authorization issues, billing issues, clinical validation and coding, what's medical necessity, and separate what's medical necessity from what patient status is. And then we have a few that are left in miscellaneous. Once we get into the root causes and stuff, and we've looked at all this, we've got our taxonomy and stuff, then we analyze the data, looks for trends, hotspots, where things are upheld, overturned, what the time to response from the payer, which is really critical, and then look at some of the payer variances. The fifth thing that we do after we've now looked at all of this and we've identified the trends, we try to identify targeted interventions. Some things need to go back to payers for policy updates, provider education, and then lastly, having a good dashboard where you can measure the impact and close the loop with a governance structure, which we'll talk about. Next slide. So one of the things that I'm just going to give here as an example is looking at taxonomies. We try to distinguish quickly, and we're going to go in this a little bit more, and I'll give you some examples of, patient status being one category and 2 midnights. And the patient status obviously relates to inpatient and observation. Documentation issues, medical necessity. Medical necessity is very different from whether a patient status, whether it's an inpatient observation. Now I'm looking at the level of care. Should the patient have been in the ICU? Should the patient have been in med surg floor? Should they be in telemetry? I'm looking at the NC-LCD mismatches, which we see a lot of it. The readmissions, are they avoidable, non-avoidable? And then where we have unstable discharge justification. The next category that we typically look at, obviously, is documentation, and could be very separate from CDI. You guys are very familiar with that. Do we have clinical validation? Are there things missing? Checking on the problem list. Then we see another category of cases that come under intra-facility transfers. And this is where we have no documentation for higher level care or weak exceptional rationale when the patient is being accepted. Authorization becomes big. Was it late? Was it missing? Did we have the incorrect payer? Did we get those clinicals updated? Are there gaps with post-acute authorization getting those discharged? And then finally, there are coding and DRG issues. So, of course, here at Peer Watch, on the appeal master side, I have clinicians, doctors, nurses, nurse practitioners. We have coders, we have certified CDI specialists that work in all these different spaces. Once these cases get classified, then they go to the appropriate person that works them. But in a hospital, it could be very different of who the primary owners are, and primary ownership is very important. Next slide. So the root cause is really, really, really important. And one of the things that we saw earlier with a lot of clients earlier is not having a really good root cause denial reason issue. We have about 68 of them. People say, wow, that's quite a bit. Yeah, but they're very clear descriptions. They're categorized. And I gave you a couple examples out of our list. The definitions are very well defined, so that when people are actually selecting them, if you don't have good, clear definitions in our software, basically when they get ready to select one of this, they can hover over it and it defines them for them. So if you're going to cut out variation and you want to making sure people are using them correctly, you need to make sure that they're clearly defined. We take ours a step further and we add who's the responsible party, whether it's the payer or provider. And then, of course, when we get down in the hospital setting, you can go down even further that says, yes, it belongs to the provider, but the provider is case management or the provider is admitting. But when we work with our hospitals, we basically say, listen, this is a payer. It is unavoidable. So, for example, when the payer advised that the authorization was not medically necessary, and then they deny that, that's a payer issue, and it's unavoidable in the hospital if that's truly that the payer has decided. So we really have taken the time to go through and put together root causes from with our years of experience and getting these cases back. It's one thing what they tell you on the EOB that the issue is, but then we need to really be able to identify what the root cause is. They say it's authorization. Is it authorization because we didn't notify the payer, or we somehow didn't get the right payer, or is it authorization because we have notification but case management, or let's just say UM failed to provide clinicals? Those are different issues. And if you don't get down to the root cause and you don't have very good, clear descriptions and definitions, it's very hard for you then to start putting together action plan where all this need to follows. So we don't when we talk about medical necessity, and I just left the example here, in our medical necessity, there are different things like level of care. But if we're talking about whether they should be an inpatient or outpatient, we look at that as inpatient status supported correctly or incorrectly supported, where there are system or process issues that cause that. And you can see under our one where we said level of care, we very clear that you use patient status for observation versus inpatient, and we use this strictly for ICU versus med surg and so forth. Next slide. Okay, so one of the other things that we also do is that we take and we look at cases based on whether they were high volume, at the high volume cases, low return rate, whether they're high volume at low or high volume, low overturn, high overturn, then low volume and low volume, high overturn cases. And cases that we find typically that are high volume with low overturn rate, typically what we find is there's some sort of internal workflow going on in the hospital, or something going on with the UR decision there that you can see. If we're looking for cases that are high volume and high overturn rate, usually they help us look at there's some sort of payer behavior here. There's a lack of understanding, as Dr. Smith always reminds us when he gets into them, can look and see, wow, they're very high. There's obviously a mismatch somewhere here in criteria of maybe what the payer is doing on their side. Or I see a lot of high volume and high overturn cases because when I look back at the notes, I can tell that the UM department didn't necessarily get all the clinicals in, and now they're denying the cases. So you're running on the back end trying to figure out what's going on. For low volume cases and low rates, we usually have to provide, target education. There's usually some sort of local policy or something in decision support we find that are issues. And you can see it for low volume cases, and they have a high overturn rate. We say, oh my God, we identify those and appeal those very quickly. But then we keep an eye on them. At some point, we might need to go back for peer discussions. Next slide. So now I want to just give a couple of quick examples here. And that is to talk about an example of a patient status with the 2-midnight. So some of the things that we see a lot of short stay that are maybe clustered in several service lines. We saw this in one facility typically, and then it lacks the documentation that's needed. Or the UR escalation happens after the discharge, which is kind of too late. So the root cause of this, obviously, when we get down to it, is a lot of these facilities do not have very good gatekeeping at the front door, which typically in these cases in the ED. And then we see that the physician articulated something very different, and then there's a lack of case-by-case exception in the documentation. And so we talk about what some of the interventions that we need to have there. And Kendall, I think this is a good time for, we have a separate presentation on just the 2-midnight rules and the changes, but could you just speak about what documentation that we typically see that's missing with physicians? You're on mute, Kendall. You're muted.
Of course I am.
Mhm.
It's rare that I'm actually quiet. But I will say this to you, Reggie. Reggie is a stickler for detail, and it has impressed me. It has convinced me of the power of what we're talking about. The ability of these reports to drill into specific operational vulnerabilities, areas for improvement that he has been able to lead and deliver to our client hospitals has been eye-opening through the processes that he's outlining. As an example, and then I'll speak to the specific issue that you just brought up with physician documentation. Following the strategies that he's outlining, we were able to look day by day of the week, and I think we'll get into this a little bit later in the talk, and see the impact of support staffing on a specific day of the week, maybe a Friday or Saturday, with a spike in denials occurring 24, 48 hours after that, and made recommendations back to hospitals and able to quantify the impact of short staffing on weekends. We able to identify spikes in denials coming in on Mondays, probably for elective surgeries and procedures where authorizations may not have been completed. So the granularity and the operational detail that results from this process has been really eye-opening to me, in terms of its ability to lead change and improvement. As a physician, one of the things that I'm always focused on in denials is the role that the physicians play in denials. Denials can obviously originate from administrative, technical issues, not getting authorization, wrong types of authorization, etc. More often than not, especially the medical necessity denials, which probably make up 90% of what come across my desk, relate to less than optimal physician documentation. And the payers have gotten very used to the smart phrase, to use an epic terminology, of two midnight expectation, which says I expect the patient to spend more than 2 midnights in the hospital, yada, yada, yada. What we found to be helpful with this is more specificity. And we've recommended, based on some of these reports and drill downs, that hospitals develop a best practice of having physicians document specifically why the patient needs to be in the hospital more than 2 midnights. So that changing that smart phrase from a checkbox to something that's a fill in the blank and describe why they're going to be there. Does that get to what we were thinking about, Reg?
Yes, yes. So we have a separate conversation, a separate presentation that we're working with our clients on in the 2 midnight. And quite frankly, if you guys are following 2026 and the expectation of what CMS is allowing the payers, what you guys are going to notice is that the checkbox is no longer good enough. They're going to have to do exactly what Dr. Smith. They're going to have to be able to specify, because the conversation that was had with CMS from the peers, which was a very good one. Number one is that many of the patients are staying greater than 2 days because hospitals function Monday through Friday, and on the weekends they're providing hotel service. And then on Monday they're doing cardiac caths and GI procedures on patients. And so what they're really looking for is, as Dr. Smith talked about, is if you're saying you're going to keep them 2 midnights, tell me the clinical reason why they need to stay, why it's going to take you 2 midnights to treat them. And if they get better soon than that, you need to tell me that as well.
Yep.
Next slide. And so some of these, like I say, I'm not going to read to you. You have access to them. The biggest issue that I will tell you that we see on interfacility transfers, and we talk about what those common denial reasons are and what the data shows us, and standardized, obviously getting a bundle. The biggest issue that I would say, especially with multi-hospitals, is that they move their patients back and forth around from one facility to another one, and then send them back to the original one, and then they get discharged from the original one they get to. And so for those cases, it's going to be real important that even if you're in the same, unless you have the same NPI number, it's really, you're going to have to get an arrangement, and they're typically going to their higher level hospital for things that can't be done at the lower level hospital, and then they're sending them back. But what they're trying to do is bill both of them, and you can't have inpatient services. Excuse me, you can't have outpatient services on an inpatient claim. So a lot of these need to be getting some agreements back and forth. I'm going to send the patient to you, but then you need to send me a bill so that I can add to that particular DRG. Some of you are very aware of that, but these are some of the protocols that we see that are inconsistent. Next slide. The next slide provides some potential interventions that I think, as we talk about interventions, you want to make sure that you have interventions that are repeatable, measurable, and owned. These are just some of the interventions that we have been able to identify with our clients as we help them develop their plans, making sure they have front door huddles, making sure that if they're using guidelines to evaluate the severity of illness, intensive service, as in MCG and NQAL, that if the patients don't meet those criteria, then how do they get those things escalated to physician advisors? What kind of observation treatment protocols that you have? A lot of these patients, when you look at them, there are signs and symptoms. You've got good old syncope, you've got good old gastroenteritis, You've got just plain old chest pain. What kind of observation treatment protocols that you have where you can get the results back fairly quickly and to decide whether or not they need to be moved from observation to inpatient. And then under the case management piece, obviously, though things are case by case, do you have 7-day and weekend coverage? Because that's going to be big as we move forward. And as you're trying to justify things as we move into 2026 with all the changes that are going to come in for the MA changes in 2026. And then for payment engagement, we'll talk about that in a minute. And then audit response. Do you have a centralized way of tracking? And I mean a good tracking, a good software system, and you'll see some of the stuff that we have in our system and tracking so that you even know where to take it to the payer. And lastly, it's going to be impossible to make it through this without having some sort of denial and prevention resolution council where you take all these action items in and address them. Next slide. So I want to talk about payer. Dear Dr. Kendall here, sorry to bug you again, but we need to talk about this escalation and payer accountability. And so if you'll just take a look at that real quickly for us and provide your feedback. You do a lot of discussion here.
So we do a lot of discussion and working with physician advisors in the hospital setting, CFOs and senior rev cycle people. Data informs and empowers people more than anything. We routinely provide these reports back to them for payer meetings. We may see examples of situations where either process improvements are needed at the hospital side. More often than not, there are actually payer discussions that need to happen. We use a appealability scorecard that we've talked about in prior presentations to rate the strength of the appeal based on the reason for the denial and the facts in the record from a 1 through a 5. And routinely, when we're getting cases coming back that we predict based on the denial letter, the reason stated for not paying the case, where we've shown by clear and convincing evidence that those facts were wrong and those cases are upheld, we're able to bundle those and report and send them back to hospitals so that they can handle them in payer discussions, take them to mediation or arbitration. But again, what we're talking about is aggregating data across payers, across systems to learn about both performance opportunities on the hospital side, but engagement discussions on the payer side.
Great.
Right.
All righty, next slide, because I want to eventually get to our little dashboard to talk about a little bit more. So just kind of an audit response for the audit for looking at this for respond, recover, and prevent. You really are going to have some sort of way of having to be able to look at your data. I've looked at a lot of stuff that a lot of our clients have brought to us out of the mainframe system, and they're really not denial management software. So we have lots of clients, as I say, a lot of big health systems. We're linked with them through their Epic, through Veracity. We're able to send stuff back and forth to them so that they do have the information that we have from their denials to get back into their patient accounting notes, so that either their staff can work it or our staff, depending on whether they're doing the Appeal Master Service or the Veracity one. But you'll see in a minute that robustness of the data that we're able to pull out from the medical records, and then from the denials, and then validate the scope and the deadlines. You need to know the deadlines of when this stuff is due. If you don't know when that you only have 60 days to do this, and you can see that you have 180 days for level 1, but you only have 60 days for level 2. You've got to have some sort of system to crank that in, because you can get a lot overturned at the second level that you may not, and I'll talk a little bit why you see more at first and second. And then you've got clinical review, all the stuff is there. We use standardized templates to draft our appeals following the 2 midnight expectation, at least looking for the clinical reason why the patient got there and why they need to continue to stay. You need to be able to submit and confirm that they got receipt, because you'll get a lot back from payers that said, oh, well, we didn't get your appeal or whatever. We have great tracking mechanisms to track back to say, yes, you did. Here's the day it was received on, blah, 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 blah in the system. and then escalate when criteria and policy is inconsistent. Obviously, looking at quantify the impact and your appeal effectiveness, and then some post-mortem fixed. Next slide. I want to talk about the fact that it's very important that you have a denial prevention resolution council. I'm going to remind everybody that this is not just a revenue cycle issue. We need to get HIM and all these guys there to look at the data that we're able to bring with them. Weekly huddles are great for looking at some of the hot spots. I would say monthly data is even better when you can bring in other people like cardiology, the other areas that where you may be seeing in a service line that you're having particular issues. And then some sort of quarterly meeting also where you can put together a packet for your peers. Some of you have joint operating committee meetings, oversight meetings. I would suggest in my last location, we were able to have a separate meeting with the appeals team and the medical director, as Dr. Smith talked about the importance of the medical director on both sides, to talk about some of these appeals, because some of the denials are pretty egregious. But this is where you actually work with the data and you pull it out and you move forward. Okay, so I left you a sample of a standard meeting that you want to do, which would be great. Next slide. Next slide, please. Okay, Eric's slides is moving. Are you there, Eric? Okay. Yeah, I just talked about this, Zero, about having a governance that sustains your results. Next slide. I've left you a sample agenda you can look at in there to look at your stuff. Next slide. Okay, and then I just wanted to show you kind of what you might want to do. I'm also a quality person, big in quality. This actually would all be on one line, but you can see what we typically do is we download all of the denials from the system to provide to the organization. They began to look at those cases. They're looking at them by what day of the week did they come in, how long did they stay, where are they current in the stage or the decision, depending, we're waiting to hear from them, where they are, what their issue that they said originally was. Gives the hospitals an opportunity to look to see who, to write us a brief summary of, tell me, like this patient, and like I say, this would all be on one line, but I couldn't get on one line because it's, we're on a PowerPoint, so but get the people that are responsible to review these, get them out weekly. We sent them out weekly to the staff. They get to put a brief summary. What are they going to do to mitigate it? Do they have an action plan? Who owns it? Which department owns it? Always has to be ownership. And then what are they doing as a project to monitor this, to make sure that as much as possible, if these are internal things we have, that they're actually going away. Next slide. So I want to go to a quick case study. That's what I want to get through real quickly to talk about data. We have all kind of dashboards in our system, but what we try to do is also for an operations review to pull this stuff out in something like an Excel or an Excel BI, because we have various things that we can look at. So next slide. This is a sample facility that one of our sample clients that we have, that I pulled some of their data to look at, blinded them really nicely, so you don't get into that. Next slide. We can able right here. Yes, we're able to put, no, you go back one like you were, Eric. We're able to look at what year. Sometimes we have multiple years, whether they're inpatient, outpatients. We get all the service sites that were available. We can select by issue, and because you're actually the way you have this set up, I can choose just to look at all this by patients that were in for 1 day or 2 days, or just a particular payer. Once I dig in, it always sends me back, because I have slicers on it. I can come back and look at that particular hospital, or if I'm looking at that particular payer. We look at everything pretty much by payer plan, because all of you guys know for sure, if you're doing this kind of work, that just because it's United, it could be, is it an issue with United Commercial? Is it an issue with United Medicare Advantage? You may have multiple payers. However you have your stuff set up, it'll pull it over, because in the system, this is how we bring when we're doing we bring your data in this way, and we're able to then take and sort it back out. And then, so even though I'm going to show you looking at it as a whole, I can come back as I start seeing trends and stuff. I can come back and look at that particular pair or look at that particular stay. Next slide. So I'm going to run you through the dashboard real quickly, and then I want to hopefully leave some time if there are any questions for us. We look and see what's open. What's open by every particular payer plan. That's important to us to know. How many cases do you have open? Who is the payer? I know I have that many open, but then I need to ask some other questions and we'll get that. Then we look at it by facility, because what we try to do at some of our clients that have multiple facilities, they like to, because all of these reports also that you're getting ready to see go by facility, they can click on that facility and send them their own reports of what they do when they meet down with them. Next slide. Then the important pieces that I need to get to is how many cases that you have open and how many of them are setting that it's their average time that we hear from them. At this hospital, their average level 1 cases, it takes 131 days to get an answer. That to me could probably be a problem. Then level 2 is 126. Then they have some cases out there that are at level 3. And you can see the number of cases. I already told you how many opening, what the dollars are. Now I'll go to the next slide. Now I can tell you on the next slide, who's the payer plan. So if you're going to work in this space, and as Dr. Smith says, and you're now talking about you going to payer meetings, which plans, what do you have? Some of our clients do a great job of putting together spreadsheets for their peers and saying, we have 317 cases out there. They know how many days they've been setting out there for each case, because we can drill down to the individual cases in there to force them to give them an answer on them. They've got deadlines for you of when you need to get it submitted. You need to have some sort of sense of how long it's taking you to get an answer back from them. Next slide. Then we start looking at closed cases. I can tell you that on an average, we all know that the average overturn rate for facility overall, or for denials period, is somewhere between 35 and 50%. So now I'm very interested in, okay, which pairs are we doing well with? Which pairs are we not doing well with? Because then I might later on, like I say, go back to the front and pull up that particular pair if I have enough volume in there. But in this case, you can see this hospital seems to be doing very well with this overturn by payer plan. And we drill it down. It closed by payer plan. Next slide. We drill it down by hospital. So we know how, if there are any particular facility that's having issues, then we can go back and see, okay, what DRG is it? What is it that you go down so that you can actually do a great assessment? Next slide. Then we want to know about overturn rates. And the next slide, Eric, if you'll move on, great. And this next slide, I'm very interested in if I'm having overturns, when are they getting overturned? Are they getting overturned at level 1? Are they getting overturned at level 2? Are they getting overturned at level 3? We found this to be very, very powerful, because in most health plans, the first level reviews are done by nursing staff using strictly Interqual or MCG or whatever they have. When you get to the second level, because it's required that all health plans have physician advisors, and most of them, it is done at the second level, you can get significant amount also done. This hospital is getting almost 19% of theirs overturned, because once you go to a physician just doesn't look at Interqual. They look at the whole case. They look at all the comorbidities, the risk, and all that stuff going over. You can get a lot of it done because there are some smart nurses. I've got smart nurses that are writing these things. They are nurses that can see, if you write a great appeal, the totality. If you say, if you're not careful when you're dealing with Interqual and MCG, they go to one thing. Oh, the primary diagnosis was CHF, and they don't meet blah, 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 blah. But most of the Medicare population has more, as you guys know, than just CHF. There's diabetes going on, there's COPD going on. And so it's really writing the totality of the case that I think that really helps with getting this thing done. And so you need to be able to know where you're getting them overturned at, And like I say, I can go back and then choose a pair if I want to and see if it's United or Humana. How well am I doing with them individually for their cases? So that's really important. Next slide. Then we look at what are the closed reasons. So again, we talked about taxonomy. Taxonomy is why did this case get closed because everything we've got exhausting, or are we getting overturns because they're overturned, or did the client rescind it? Having great taxonomy that you can actually go back for overall closed reasons. Why was this case closed? So that's important. Here you see the majority of theirs are done by overturn rates. I want you to back up for me, Eric, if you don't mind, and then I'm gonna move back forward and just move back about 3 slides for me. I think this is as important. You can right there, stop right there. I think it's important that when you're looking at overturns, you not only look at the overturn rate by dollars, but you also look at it by volume. A lot of people only look at it by dollar. We look at it both by volume and dollar, and how well we're overturning these cases. Okay, you can speed up for me again one more time. And thank you for that. Then we're done with that slide, Eric. You can go to the next one. Then here comes the big kahuna, because we have very detailed root causes. I'm now trying to get down where are my issues in terms of why I'm not, what are the actual root cause? I know what the issue was. The issue comes on the EOB, basically tells me nothing except for 50, 150, 39. These cases are being denied for medical necessity. You tell me it's 249, it's readmission. You tell me it's 197, 198, it's authorization. Okay, but it's authorization. But what is the issue with the authorization? Was it not obtained? Was it not on the claim? And this one, was it obtained, but the incorrect date or place was done? You can see it. We found that it was not on the claim, but we can also see on cases where it was on the claim, you said it was denied. That's unavoidable. You need to fix. They need to fix that. So we are very descriptive. So I can actually look at what is actually the true root cause. And again, when you see these, we don't only just do it by root cause by this. I didn't put all that. We didn't do root cause by pair. So we have a tab where we run them all by pairs, and then we can go down it real quickly. Is there a particular pair that we're seeing issues in for those? So I'd be very, if you're going to really do a good job with interventions, you're gonna have to have a good root cause table so that you can really run it up run it by plan, by facility. We run it, as I told you, we run this is the overall table, but you can see at the top, I tell you, we run it by plan, we run it by facility. Is that we find out that there's some facilities that have issues with authorization. There may be 30 hospitals in this system, but all of them, but if they're not centralized in some sort of way in some of their functions, we can then go into this one and say, at this facility, you have an issue with authorization, and then it's affecting your ability to be able to get paid. So then we're able to look at it in terms of that nature. Next slide. Then the big kahuna for me is what DRGs are driving this. We take the top 25 DRGs. How well are you doing with overturns those, but what are they? And I can see here at this hospital, they're having issues with good old syncope and they're not getting great overturns with that. It makes us go back and ask some questions. Why? We've got esophagitis and gastroenteritis. Probably those patients probably should have been in observation. But if we don't have a way to be able to share with them to say, these are your DRGs, and by the way, Aetna is having a problem with this DRG. And so we have a different dashboard for clinical validation because, as you know, with clinical validation, we need to be able to get down to the codes that they're doing. But in this case, I can really look at a high level to be able to tell them which DRGs are we successful with overturning. I would also caution them as well when I say that, okay, I'm seeing a trend with this one, I'll go back and look at the 1-day stays. And if I see here the septicemia is part of your 1 or 2 day stays and the patient didn't die, I'm like, you're probably going to have an issue soon with clinical validation with these. So some of this stuff will lean you back in to look at it at another perspective. Next slide. I'm very interested in 1-day stays. How well are we overturning 1-day stays, and where we're not? Again, I'm gonna look. We look at them. We look at the 1-day stays separate from the 2-day stays. It looks like if they stay 3 days or 3 days or greater, we will pull up those DRGs, look at what DRGs are driving in each one of those sections. Then begin to have some dialogue with them of what probably they're struggling with that are 1-day stays that we're having problems getting them overturned. However, to see that you having a pretty decent rate though, and 1 and 2-day stays, you know, a lot of that I will tell you has a lot to do with our appeal template, and as Dr. Smith said, the education in providing people with this client having great conversation, getting the physicians to start doing better documentation in terms of not just telling me that the patient needs to stay 2 midnights. Tell me why. Because I can take that to court. If you can tell me, I can take it to the ALJ and to other ones if I have good documentation in that space. Next slide. Then we get to Dr. Smith's favorite one. Dr. Smith, come off mute. This is your baby right here. If you'll provide some quick feedback on this one. We only have a few more to go.
Yeah, we alluded to this earlier. And done webinars on this in the past, which is the appealability scorecard. And we've been surprised in some cases where we've found some payers where we actually predicted that they would not overturn, where there were missing authorizations or we thought there were critical gaps in the documentation. But with a strongly written appeal, that we were more successful than we had expected to be up front. We generally do see a pretty good distribution like this. I think the take-home message is appeal essentially everything that you can get your hands on. In some payers and in some systems, even the ones that we rate a 1, we do see a 5, 10, 15% overturn rate, which does surprise us time to time. But that speaks back to Reggie's earlier reference of using a structured narrative and buttressing it with legal arguments has always been one of my preferences. But certainly focusing on the high dollar, greatest opportunities, the 5s and 4s, that gives you some good information to take to a payer meeting, to your CFO, to internal counsel, and say, listen, we've got a problem. These are being upheld. We know these should be overturned. And this has been a simple but invaluable metric.
Thank you. So I think that's just my greatest takeaway that I've learned that I mean, I came with a lot of knowledge, but I was really excited when I saw these, and I review these cases, and we're saying, listen, you medical directors need to go find a medical director at the payer real quickly. I mean, there is no way this patient came in, is on a ventilator. I mean, they're a hot mess, and how they got upheld, and we score them as a 5. I mean, you can't send them home on a ventilator. So, and they're acutely ill. So why did we need them? So which tells me that sometimes everything doesn't always get looked at. Next slide. I like to put the next slide in a Pareto chart, and we have great conversation. We talked to this hospital and say, it's very interesting that most of the cases that you have got denied on Monday. And I mean, Dr. Smith, they obviously had conversation, do a drill down, and found out that these are a lot of cases that actually might have came in on Monday, didn't get authorizations. We went back, we saw that, it's Monday. And and it's authorizations. So these cases probably have a lot to do, as he said, with surgical procedures. We look at this very closely because some of the clients I can see that they have a lot of their cases that got denied. When I put them all together and Pareto them, they tend to be weekends, which means it seems like you got case management going on during the week. You don't have anything there on the weekends. They're short stays. So we can go back again, like I say, the slicer, and choose those things so we could provide some education. So I want to take a quick takeaway, and then we got 5 minutes for questions. I was hoping I had 10 minutes, but I'll do it to see if we have any questions in the chat we can talk about. But using denials to reveal workflow issues and breakdowns is really important. Making sure you classify things correctly is important. Building scalable fixes, standard work, looking at documentation we just talked about. And you got to have a good dashboard. Some of the stuff that I see in Excel that people have sent me when we first take them on as clients, or we're looking at their stuff, I don't even know how they even are able to come up with a plan. They don't know when the appeals go out. They don't know how long it's taking. They don't know what level they're at. Everything is listed as denied for medical necessity. I don't know what that means. So once we get started, this hospital that we had first, that very, very low overturn rate, but it's very, you can tell as we go along every quarter when we meet with them, their overturn rates are getting better and better. Their documentation is getting better. And hopefully that's the takeaway that we want you guys to have, is that you've got to have a great dashboard, but you have to have data to put in it. And so you got to have some sort of system, some sort of way other than just having it on the sheet and say it's all for medical necessity, because it's very hard to do any quality and put anything to it. So let me shut up. We've got about 2 or 3 minutes left. Do you have anything in there particular, Eric, that you heard from anyone
Yeah, we
that
got a
has a
few
burning
questions.
question? Sure.
Yeah, we can probably hit a couple of them. So one, what do you do if the payer does not respond to a hospital request for authorizations? So clinicals have been sent, et cetera.
Oh, we have that. That goes into the appeal. So we are able to show in some of these cases, if the UN people do a great job of documenting there, and we can see the forms in there that says authorization was requested and it wasn't received, we write the appeals. And again, that's trackable, because now those are things that I'm going to take to the joint operation meeting. We have this number of cases. It's the data that drives it, that when you get to those meetings, it's hard for these people to review when you put the data on the table. But you can't take one-offs. One-offs don't work very well. You've got to be able to take trends and patterns. And so when we do that and set that before the peers, things, they know what we're watching. They know we're watching. They know we have data to substantiate it. Different conversation. Great question though. Next question.
Next question, can you speak to the Two-Midnight presumption and how MA plans post-claim reviews of services that were prior authorized but may not be reopened?
Okay, so there is something there is a, I wish I'd have, that's in our another whole separate conversation that we have. MA plans, okay, do not have to honor presumption. It's just because a patient stayed 2 midnights means nothing. It's really the benchmark. It's the fact that the physician declared that it's going to take 2 midnights, but now it's not just the declaring that they want. If you read very carefully in 2026, is they're looking for the clinical documentation. So what CMS told them as we move into 2026, it's not just the benchmark, it's the benchmark plus the clinical the clinical validation that the patient met the criteria to be there. So that's the difference that's coming up. So just the checkbox is not going to get it anymore, because they did a great job of saying, yeah, they checked the box, or they presume because the patient has been there 2 midnights that they need to be paid for 2 midnight, but they didn't do anything for the patient from Friday to Sunday other than provide them a meal. That's all they did. I mean, they didn't do it. There was no intervention whatsoever. And then on Monday, they get the
Two hots in a cot waiting for a stent on a Monday morning doesn't constitute 2 midnights. It constitutes a hotel stay or a medication.
And that's basically what they won that war when they put their data on the table to show how many claims that they receive from hospitals where patients are having nothing going on. They're waiting on Monday for the GI doctor, or waiting on Monday for the cardiology team to come in. And those were the two areas that they spoke about, GI and cardiac. Those are the two biggies. but great question. Get me another one.
How do you classify Aetna's new policy of classification of severity? They approve inpatient, but then they state they will pay at a lower severity rate. How do you track that?
You first of all, you're going to have to do something on the patient, on the revenue cycle side, okay? Because what should be happening is the revenue cycle should have a way to know what the expected payment is. That becomes a payment variance. We're receiving some of those cases now. They're not, be very careful, because Aetna is not the only one doing it. They're the only one to open their mouth about it. If you look at some of the claims, you will see United paid an outpatient rate, but the patient was an inpatient. And we can see they threw them a bone. In some cases, they'll throw them a bone and just pay for the ED. But really the claim is denied. And even with Aetna's, what they're doing, it's very clear from Medicare, and it's very clear from Aetna. You can still appeal the claim if you feel that the patient met inpatient. But it's going to be important that the revenue cycle has a way to know exactly through some sort of their contract management system what it is they should be getting paid from an inpatient basis, and then those cases have to be appealed. Great question, but that's the only way around it to do it, is you got to know that you have an underpayment. Give me another one, please. Don't leave. There's people I know have good questions.
Yeah. Any experience with second level of appeals with HMS and their required form that is very time consuming?
All of them are. I'm familiar with HMS. Even when we're going to the peers for our escalation meetings, and those of you that do this work, you know, Humana has its own layout, the way stuff has to be put in, United. And so we have built some templates that will take the data and put them in that format, including the comments to show all the follow-up that we've done. And we take those to the JOC meetings with those peers in order to get some response from them. And that's why it's important to know how long, if we see pretty much that we haven't received any response from you, depending on the contract, in 60 and 90 days, you go on their form and their format with all the follow-up that we did and all the conversation that we have with you, and you're saying you need more time and you need more time. We're taking those to those are the things, again, that's data, great data that you can take to those meetings. And believe it or not, they will take those sheets back, and typically we get something back in writing on those Excel sheets. We get a response. A lot of this is people knowing that you're watching them, you have data, good data, and that you can bring that data forward to them to get a response from them. Great question, though. Great question.
Yeah. Complaining without data is just whining.
It's just, that's what they call it, just whining. You got to have data. You got another one, Eric? I know some people may drop. There may be some people.
Sure. Yeah. I mean, this one might be answerable or not. There's a kind of a two parts here. One is a comment. Epic's not very good at tracking appeals as far as tracking the time it takes, et cetera.
Sure.
Have any insights onto how some other organizations are tracking this information at the detail that we're displaying in this presentation? So we can, I'll let you.
Yeah. So basically, to be fair with Epic, as you guys know, it's a mainframe system, and I would say that from my experience, I would say over at least 90% of our clients are on Epic. Okay, so and it's a good mainframe system. It was never designed to audits and denials. This is a whole separate world. So what we basically do with our clients that are on Epic, we have a way where when all the data, what happens is we get a feed from them of their denials, and I can't speak to it all to the detail that I could. We have to have our IT people here, but we get that feed from them. What we do is we have an interface that goes back into Epic to the patient accounting side, and it gives them all of our notes. We upload all of our appeals. And if the hospital doesn't do it, if they're doing that through our appeal services, we upload all that information back into Epic. But we run reports because the hospital is linked with us through veracity, through our denial appeals system, and then basically you can run the reports out of us all day, but you're getting the data back. Like I say, the follow-up, which is what your PFS people need, the appeals is what your people need, the overturns and all that stuff is going back into your system. So that's kind of the interface we have with Epic, and whoever that facility is, my name in my information is down below. You can either reach back out to me or to Eric, and if you guys need a demo of something of that nature, of how this all works, probably Eric is the best person. But if you send information to me or Dr. Smith, we'll get it back over to Eric Nim, and they can give you guys a demo of how this might work in your setting. But that's a great question.
I know we're over time, but I'll throw one more out at you.
Okay.
Obviously, folks can leave if they need. So anyone that is still on that might jump off, we will send answers to all these out as well. But let's end with this one. How are you handling MA plan denials when the payer is making up their own complex medical factors and denying despite outlining every complex medical factor present? 2 midnight benchmark is easy, getting hammered on the complex medical factors.
So the way you handle that, again, is you do a great appeal, okay, which we do. We do great appeals in those cases, and then we rate them, as Dr. Smith talked about. We do a rating on those, and then once we do that, we try to we work with the hospitals and the health systems where they have these medical directors, and we take these cases that are good and great, and the medical director at the facility level or the system level takes these cases, because they're egregious. They take these cases to the medical directors of these appeal units of these payers, and have had much success in getting them to read the appeal, go look at the record, and get them overturned. I would suggest to you that what we learned, and I know this is true, is that I'm not sure that all the cases are actually being written. I don't want to accuse people of rubber stamping, but I will tell you, when you read some of them and we have the medical record, it's like, no way. I mean, this patient is really sick. When we put that before the appeals director at a particular payer, and they look at it, they recognize that something happened, that this case should be overturned, and they later, in many cases, will overturn those cases. But it's that relationship that you're getting between your medical director at your institution with the medical director of the appeals unit. We've got to build relationships with each other, and doing that has been very helpful and successful in getting those overturned. That's a great question, but again, it's taking the data, taking the cases, having them looked at, and taking the egregious ones. Lets them know two things: I'm watching you. The squeaky wheel gets the oil. When they know that an organization is really taking appeals seriously and they're actually monitoring them, what we've seen in a lot of those hospitals, their appeal rating goes up because their cases are actually getting read. And if they're going to slack anywhere, they're not going to slack with anybody that's bringing them data and bringing them individual cases to look at. Great question, though.
Great. Well,
Thank
I know
you guys.
we
Yeah.
went over a bit. Yeah. So go ahead, Reddy. You can.
I really want to thank everybody for your time. I'm very passionate about data analytics. I'm very passionate about, Dr. Smith and I are very passionate about, it's kind of like why I left the hospital to get in this sort of space. Very passionate about this, and especially where we're at today in healthcare. This is very critical for hospitals to be able to sustain their margins. And so the work that we do is, to me, is very powerful, and it's all really to help the hospitals. So thank you guys very much for your time and attention. Dr. Smith, you want anything to say? Okay.
No, I'm gonna let Reggie have the last word.
All righty.
Thank you.
Well, thank you guys, and thank all of you guys that work in this space, because I know a lot of you guys are working in this space, and it is a lonely place to be, but but it's very rewarding. Thanks very much. Have a good evening. Bye-bye.
Thank you all. Bye.